Hello, everyone. Thank you so much for being here with me today. This is the third and final lecture in this series on all things normal bacterial flora. So if you did miss the first two lectures by chance, no problem at all. They can be viewed on our DSL website under Learning Resources. So please go check those out. A quick recap on what those lectures were about. The first one, I discussed the general roles our normal bacteria play in our GI health and our overall health. And then the second lecture was all about the normal bacteria that we test for on our GI map. So I had the opportunity to go into detail about each of those that are listed on the bottom of page 2 of our test. And then I got to discuss, what would cause them to be in a state of deficiency or in a state of overgrowth, and then some real tangible treatment considerations based on the state that they're in. And this last lecture, I'm so excited because what I get to do is I get to pull all the information together from the first two lectures, all the information that I extrapolated from the research articles, from the literature, and I get to apply it to real life cases. So most of us here are practitioners. We're dealing with patients on a day-to-day basis. So my goal was really to illustrate the bridging between the literature, the patient's clinical presentation, the lab, so interpreting the lab, and then getting some treatment plans together that are going to provide our patients the traction that they need for their health. So let's not waste any more time. Let's dive right in. The first case that I have prepped for us today is a 42-year-old female. And she's experiencing some weight loss resistance. So it doesn't matter, what she's eating, how much she's exercising, that weight's just not being shed. She's having some immune dysregulation. So psoriasis, chronic idiopathic urticaria. She's got an adult onset allergy to cat, was never an issue when she was younger. And she's experienced some post-concussive symptoms post-COVID vaccine. So had a huge inflammatory response to that. She's also experiencing low energy. On lab, we have low B12 and suboptimal iron. And she's been on an estrogen-based birth control pill for her entire adult life. So we do know that oral estrogen has been shown to modify intestinal permeability. So just something to take into consideration. Okay. So the three cases, I wanted to be a little bit strategic in what I was going to present to you guys. I wanted to have differing summaries for practitioners to have a bit of context. So I have what I call a mixed case, so some high and low normal flora. I have another case that's all overgrown normal flora, and then the third case is all about deficient normal flora. So I really wanted to start on this case. It is, again, that mixed case. So we've got a bit of both. And I find that most practitioners find that these kinds of cases are the hardest to interpret. But I'm gonna go over that in detail to give you some real tangible information to lean on. So again, back to our patient, the 42-year-old female. This is her test results for the GI map. And the first important finding that we found was an elevated H. pylori. So this patient isn't having any overt H. pylori type symptoms. She's not having any of that acid reflux, loss of appetite, nausea, etc. But the thing about H. pylori is that it can cause a secondary hypochlorhydria, or low stomach acid. And how it does that is it can affect the parietal cell's ability to produce HCl, but the parietal cells also produce intrinsic factor, which is really important to help with absorption of B12 and iron. So something to note, because we did see that on her labs, that yes, this H. pylori is in an elevated state, and she might not have these overt H. pylori symptoms, but it's high enough at 1,400 organisms per gram of stool, and she's got these other kind of hypochlorhydric symptoms or findings that we really would want to consider treating this. So let's get to the normal bacteria section, and this is what I'm talking about mixed in terms of there's some high and there's some low. Let's take a look at the highs first. So the first one that we're seeing is this high Bacteroides fragilis. And whenever we see this, I'm thinking, there's going to be some sort of reduced digestive capacity. So it can either be reduced digestive capacity or a digestive insufficiency or constipation, but this patient wasn't complaining of any constipation. So I'm thinking more along the lines of digestive insufficiency. And that just means that she's not breaking down her food properly. And if she's not breaking down her food properly, what happens is these microbes get to have this smorgasbord, a buffet of undigested food, and they get to really overgrow and start to overpopulate. So this is commonly seen with H. pylori infections, again, just due to that secondary hypochlorhydria. But when I do see this, I'm not just going to be assessing for hypochlorhydria, although that is a main one. I'm also looking to see, is there any decreased pancreatic output? Is there any bile insufficiency? Or is there any other potential causes for a brush border enzyme deficiency? Because those are all going to play a role in breaking down our food. All right, so that, again, digestive insufficiency. The phyla microbiota, so the phyla is one taxonomic group down from kingdom. So it really gives us a good overview, bird's eye view of how the general population of bacteria is doing in our intestinal tract. So think about 85 to 90% of our bacteria fall into one of these two phyla, either the Bacteroidetes or the Firmicutes. So when we see this high, again, we're looking at that digestive insufficiency. These bacteria are just able to, engulf and indulge on all of our undigested food. So one thing that I will note to this too is that Firmicutes does have the ability to extract or have a higher caloric extraction from the food that the patient is eating, which can make them more prone to obesity or gaining weight. So this patient is having weight loss resistance and she's got this elevated Firmicutes. So it's something that I'm going to be considering in my treatment plan of how can we support getting that Firmicutes into a more normal population size. All right, so let's look at the lows next. So we've got low Clostridia and we've got actually below detectable limit of Akkermansia, Mucinophilia, and Faecalibacterium prausnitzii. So the below detectable limit is not going to be flagged on our test. So always keep a keen eye out for that in the normal bacterial flora section. This is a normal finding on all the other sections of the test. So that's why it's not flagged on our test, but normal bacterial flora below detectable limit is a very unfavorable finding. So please keep an eye out for that. So we'll start with the Clostridia. Low Clostridia, Clostridia plays such an important role. They really help to support our colonocytes. So the Clostridia release butyrate as an end product of fermentation, and this is essential fuel for our colonocytes. If the colonocytes don't have enough butyrate, they actually autophage and die off. So really important to maintain that epithelial health. They also decrease inflammation. So butyrate inhibits the activation of transcription factor NF-kappa B, which is going to lead to decrease expression of pro-inflammatory cytokines. So really important in the inflammation cascade or preventing that. So causes of low Clostridia will be low fiber intake. A patient that's greater than 65 years of age, she obviously isn't, she's 42. And low levels are often associated with inflammatory and autoimmune conditions. So just keep that in the back of your head. Again, we're seeing some dysregulation in this patient's immune system. And then we have Akkermansia mucinophilia. So this is below detectable limit. Akkermansia is probably our best marker of how that mucin layer is doing. So it's playing a big role in barrier function. Part of our mucosal firewall is that mucin layer. And so Akkermansia increases the physical barrier in the mucosal firewall with increased mucin production. So it really helps to trigger that mucin production. And if we don't have it, then we're not going to have that nice healthy mucin production. And that mucin layer is so integral for the rest of our normal bacterial flora, but also that physical barrier function. Another really key point about Akkermansia is that it supports metabolism. Again, this patient is experiencing weight loss resistance, and she is completely deficient in Akkermansia, which is going to help to modulate the basal metabolism. So another really great note. Akkermansia is also positively correlated with a lean phenotype, reduced body weight, amelioration of metabolic responses, and restoration of gut barrier function. Sorry, there we go. And so this will start to go low when we see decreased mucosal health. So that's going to be something that we're going to want to work on. In terms of treatment, there is a new probiotic that has Akkermansia in it. So that's a consideration. Any sort of mucosal support and polyphenols. Lots of good research on polyphenols and Akkermansia. All right, and so now we have the Faecalibacterium. And so this is also below detectable limit. This is also a major butyrate producer, much like the Clostridia is. So it also helps to support mucin production. So the short chain fatty acids produced from the Faecalibacterium induce goblet cell differentiation and mucus production. So really important, again, for that healthy mucin layer. And this microbe is very sensitive to inflammation. So it's going to be, again, really sensitive to any sort of changes in the gut environment, inflammation especially, which will start to decrease its population. And this is a very anti-inflammatory microbe. So not only is it sensitive to inflammation, but it is really important to have enough Faecalibacterium to maintain an anti-inflammatory environment in our intestinal tract. And so I'll go over quickly just some anti-inflammatory mechanisms from Faecalibacterium. So the effector molecules of Faecalibacterium encourage the secretion of IL-10, which is an anti-inflammatory cytokine. The metabolites from Faecalibacterium, which are butyrate and salicylate, can block the secretion of IL-8, which is signaling inflammation. So that's another way that they can decrease that inflammation. And then Faecalibacterium enhances barrier function through providing growth factors from mucin degradation. So when they do see that, they're going to start to help with the mucin production. Okay, so causes. So when we see this low, especially with low Akkermansia, it does suggest that the intestinal lining and the microbiome in the lower gut, especially the colon, is not very healthy. So that's where we're going to want to put all of our efforts. It can also be associated with a wide range of inflammatory and autoimmune conditions. So I always get a little bit of my spidey senses up when I don't see Faecalibacterium in a nice healthy population, that, we're going to really have to work hard with this patient to maintain that immune health, that barrier function, all the things, so that we're preventing, any sort of potential autoimmune condition further down the road. So that is something that I'm really striving for. All right, so it's really obvious that, barrier function and digestive breakdown is an issue for this patient. And what we want to look at a little bit deeper is how that's affecting the immune tolerance, right? So when I just want to kind of give a general overview of the anatomy of the GI tract. So essentially we have our lumen, which contains, everything that we've consumed. And then we have our commensal layer, and then we've got the mucin layer, and then we've got our epithelial cells, and then we've got the lamina propria, which contains all of our GALT. So that's our 70% of our immune system. So there's these three protective layers that are really going to be providing barrier function between the contents of our lumen and our immune system, right? So once they start to get degraded, our immune system can start to get activated based on certain pathogens or certain contents in our lumen, and we start to see this immune tolerance get lost, right? So we're seeing in this patient that she has an elevated secretory IgA from this intestinal permeability, and I do see a lot of patients that have this start to react to everything, right? So that barrier function, again, is going to be a big priority for me to get this patient healthy. So just some important findings, again, wrapping back or circling back, that weight loss resistance, the low Akkermansia, again, really important for basal metabolism, and then the high Firmicutes, which is going to cause a higher caloric extraction from the food that this patient's eating. Symptom 2, the immune dysfunction, so low Akkermansia, big time. Same with the Faecalibacterium, really important for our immune modulation, elevated secretory IgA, and then that low Clostridia, right? So big, important species for immune support and modulation. And then that low energy, again, that secondary hypochlorhydria from the H. pylori is going to inhibit this patient's ability to absorb B12 and iron. And then the digestive insufficiency markers. So when we see the high Bacteroidetes, Fragilis, Firmicutes, and Bacteroidetes, again, we're thinking about that hypochlorhydria that is going to affect our patient's ability to absorb these nutrients. Okay, so treatment considerations. We want to kind of wrap all that information up and figure out how to treat this patient. So the first step, I always will treat patients in phases. I find that it's less overwhelming for them, and I find that we can do really good work this way and get kind of an end result that's going to be more long-term. Right? So we want to really make sure that we're not having any relapsing cases. So the first phase is always rebuilding the normal flora. So again, interesting that I would go there first because there is, that H. pylori infection, but I always get really nervous to start with eradication when I'm seeing any normal bacterial flora below a detectable limit, especially those keystone species. So I'm always suggesting for my patients to do a bit of a rebuild when I see that state of deficiency. So this could be for 2 weeks to a month, but I really want to help that barrier function before I start to do any sort of antimicrobial herbs and foundational support. So again, soluble fiber must be containing that apopectin for that Faecalibacterium. Soluble fiber, really important for Clostridia as well. GI rebuilding product, we need to get that mucin layer nice and healthy. Something with some sort of glutamine is going to help with those goblet cells as well in producing mucin. Akkermansia probiotic, again, this is just new to market, but if you do look on our tests, Akkermansia, the lowest reference range is 1E1, which is 10 organisms per gram of stool. So you don't have a big population to rebuild. So sometimes I am suggesting, let's try and seed with Akkermansia probiotic while we're supporting that mucin layer so that we can start to get that population back online. Polyphenols, again, really important for that Akkermansia. And then the butyrate is essential to supplement because we know we have a low Clostridia, we have a low Faecalibacterium, which are really, really major butyrate producers. And again, that's going to really help the colonocytes' health, right? And we want those, we need those for our barrier function for this patient. And then a low allergen, high fiber diet. So again, we want to get rid of allergens because we're dealing with this intestinal permeability. And then we want the high fiber to really feed the normal flora that's in a deficient state. And then consider a different birth control pill or option so that we're not having this added confounding factor that's going to affect intestinal permeability. All right, so on to phase 2. Like I said, rebuild a little bit when we see this deficiency, and then we are going to need to do some eradication so that we can deal with that secondary hypochlorhydria. Because if we continue to have secondary hypochlorhydria, guess what? That patient's just so much more vulnerable to all sorts of infection. They don't have that nice stomach acid acting as a barrier to the stomach that's going to kill off all these microbes with that acidity. And then, of course, they're not going to have that same ability to absorb their minerals, break down their proteins, produce neurotransmitters. The list just goes on and on and on when we have that hypochlorhydric state. So we really need to focus on getting rid of that H. pylori once we can rebuild some of that normal flora. So in this patient, I would choose an herbal H. pylori protocol just because we have that deficiency. I'm not opposed to antibiotics when indicated. But in this patient, I would prefer an herbal protocol. And I always continue phase 1. I always continue my foundational support throughout my whole treatment. So I know this is a ton of products. You can kind of pick and choose, but ideally we want to really build up that foundation. So again, we don't have any relapsing cases. So continue those phase 1, do an herbal H. pylori protocol for about 2 months. And then we get on to phase 3. So we always need to be off antimicrobials for 1 month before retesting and checking in on what the state of the flora is for our patient. So during that time, though, we can continue phase 1. So we can continue all this foundational support. They just need to be off of all of the antimicrobials for a month. And so then I'll retest H. pylori after that month. And depending on what the test results are, we'll go and lead into phase 4. So phase 4, if H. pylori is still present, we're going to continue to treat. And again, just because we want to make sure that we're not going to have that continued secondary hypochlorhydria. And then if it is gone or in a more normal range and the patient's asymptomatic, I do initiate a hypochlorhydric assessment. We don't really want to use HCl on a patient that does have an H. pylori infection, an active H. pylori infection, for a couple reasons. The HCl has been known to drive the H. pylori infection a little bit deeper into the epithelial layer, so it will chemotaxis away from acidity. And we don't want, if there is any gastritis, we certainly don't want to disrupt that tissue with any acid. So I am often waiting until I have kind of a negative or a really low H. pylori finding before I'm going to start any sort of HCl treatment. Okay, and then I generally will retest the whole GI map around that 6-month mark, after the H. pylori is gone, after you've done a ton of buildup, and then we can do an overall assessment again and just see where you're at. Okay, on to case 2. So case 2, excuse me, is a 19-year-old female, and she's experiencing dysmenorrhea with pain and vomiting. So whenever she gets her period, she is really out for a couple of days, and the pain is so extreme that she actually is vomiting. So really not fun. There is potential endometriosis based on her family history. Endometriosis is just so stinging hard to diagnose. So, no definitive diagnosis there, but there is that potential. So something to be reminded of. And then tons of digestive disturbance, stomach pain after eating, constipation, chronic nausea, again with occasional vomiting, even not surrounding her period, and tons of gas and bloating. She's also having situational anxiety, mental health concerns with being on birth control pill as well. So ever since she started the birth control pill, a lot more mixed moods and emotions that she finds is really related to the pill, and she never experienced before that. All right, so let's dive into her case. Oh, this is an overgrowth state. So just wanted to mention that this is where we see a ton of overgrowth. So let's dive in here. We're seeing H. pylori much like the case before, but now we're seeing a ton of those H. pylori symptoms, all of those upper GI symptoms. And again, there's that secondary hypochlorhydria that we have to worry about, but the acid reflux, the constant nausea, the stomach pain, this is a pretty significant case of H. pylori that's really disrupting her quality of life. So we are going to want to treat that. In terms of the normal bacterial flora section, like I said, we're seeing a huge state of overgrowth, right? And so let's dive into each of these markers, and I can just help discern a little bit of what they all mean. We're seeing some similarities. Again, the Bacteroides fragilis and the phyla are all in an overgrowth state. So like I said, we're going to look for constipation or some digestive insufficiency. Again, this patient didn't have constipation. If they do, we just want to treat the causes of constipation as well. So we're looking at this digestive insufficient picture. Reminder, H. pylori causing a secondary hypochlorhydria potentially. Is there any bile insufficiency? Is there any decreased pancreatic output? And is there any markers that are telling us that there is potential brush border enzyme deficiency? So I'll just quickly dive into that brush border enzyme deficiency. I'll look to see if there's any giardia, and I'll look to see if there's any Pseudomonas present. If there is, those are really disruptive to the small intestine lining and can affect the brush border enzymes. I don't have any cases today that present that, but I just wanted to give you that little pearl for when you do find cases like that. You're going to want to add a brush border enzyme, especially when you're seeing overgrowth in some of these markers that are indicating digestive insufficiency. So again, we're going to want to get rid of that H. pylori and look to the other markers as to why, if there is any other markers for digestive insufficiency. All right, so then we've got this high Escherichia, and Escherichia will go high, or when it's high, it can be indicative of increased intestinal inflammatory activity. So when I see this, I don't so much think like, okay, I've got to treat this. I think, all right, the terrain is in an inflammatory state. Escherichia has increased. What I want to do is I want to go and find the inflammatory microbes, and I want to eradicate them. And then I find that Escherichia will go into a more normal population size if we can get the environment less inflammatory. So something to note there. We're seeing some elevated Clostridia. Again, we talked about this one in deficiency last time. So now it's high. Again, this is another marker of digestive insufficiency, much like the Bacteroides fragilis and the phyla. And a thing to note about Clostridia when it is high is that it does contain a lot of beta-glucuronidase. And we're going to go over this marker when we do get to the intestinal health markers. But this is really important for this patient, especially with her being in an estrogen dominant state. So elevated Clostridia, lots of beta-glucuronidase activity. It can really affect the excess estrogen picture. And of course, we want to correct the digestive insufficiency when we do see that elevated. Another thing to note, I just wanted to say quickly too, is that Clostridia with the beta-glucuronidase has the ability to cleave epinephrine and norepinephrine from a bound state to a free state in the intestinal tract. So you do see commonly with elevated Clostridia that your patients are a little bit anxious or hyperactive. So one thing to note is if you see that extra Clostridia, that might be playing a role with that anxious state patient. And so we want to correct that so we don't have this beta glucuronidase cleaving your norepinephrine and your epinephrine in your intestinal tract. All right, so that's really interesting. Next is our Enterobacter. So that's this guy. Same thing, much like Escherichia. This can be from an increased inflammatory activity in the intestinal tract. Let's go find the inflammatory microbes. Let's get after them. And then we'll find that the Enterobacter will start to go into a normal reference range. High Akkermansia. So again, previously we saw this low in the last case. When it's high, we're thinking that there's elevated sugar availability in the colon because they love to feed off of that. So this can be from a high intake of carbohydrates or for carbohydrate digestion. I always ask my patients with high Akkermansia, what is their carb intake? Can we diversify their macronutrients a little bit more? Common in vegetarians and vegans to have this a little bit elevated. The other thing I remind patients is to chew their food, right? That salivary amylase is going to initiate carb breakdown in the mouth. So we want to really make sure that they're chewing their food and initiating that carb breakdown. And then I will also assess for elastase 1 found on our intestinal health panel or markers at the bottom of this test to just see if that is inhibiting, if that's low, the patient might not be breaking down their carbohydrates that well in their small intestine and also allowing this Akkermansia to overgrow. All right, and then the phyla, we talked about that too. Digestive insufficiency will drive these right up. So again, is that because of the secondary hypochlorhydria from the H. pylori? I'm thinking most certainly, but I'm also looking to see, is there any low elastase 1 or is there any elevated steatocrit in our intestinal health markers that could be telling us a little bit more to that digestive capacity story. Okay, so we are seeing a ton of overgrowth here. In this slide, we're seeing a ton of overgrowth here too. So this is opportunistic bacteria. This is at the top of page 3. And I always tell patients and practitioners, opportunistic bacteria do not grow in a healthy gut. So these are opportunistic in nature. We need to look at terrain. We need to look at physiology and see what's going on that's allowing them the opportunity to overgrow. Because if we don't deal with the terrain and physiology and we just start to eradicate these opportunistic bacteria, they're going to continue to overgrow because we haven't dealt with the root cause, right? So really, really important for us to look at, again, is there hypochlorhydria? Is there low normal flora? Is there low elastase? Is there elevated steatocrit that might tell us that there's some bile insufficiency? Bile is a major antimicrobial in the small intestine. And then the last thing is, what's the secretory IgA doing? Because that's going to play a big role with managing these opportunistic bacteria. So those are the 5 things that I really look at on a patient's GI map that has an opportunistic bacteria overgrowth. And again, want to treat those first. So this is often a phase 2 treatment here because we want to deal with root cause. We want to deal with terrain and physiology. So we are seeing overgrowth here. Morganella especially is a really inflammatory microbe. Same with H. pylori. So when we spoke to the Enterobacter being high, when we spoke to the Escherichia being high, those are the inflammatory microbes that we want to go after so that those Escherichia and Enterobacter can go into a more normal reference range. So Morganella specifically, histamine producing, biofilm producing, gram negative, LPS, all the things, nasty, nasty bug. So we will want to treat this eventually for overall picture, but again, looking to terrain and physiology as well. Okay, so intestinal health markers. Not to jump around, but I want to jump back up at that digestive insufficiency that I've been talking about because I talked a lot about hypochlorhydria, but this is where I find some of the other markers, right? So steatocrit tells us the percentage of fat in the patient's stool. And if there is some fat in the stool, we can kind of look to, is there potential bile insufficiency that's causing this fat to be in the stool that's, not broken down properly or absorbed. And again, bile is a major antimicrobial, but it's going to help with breakdown of fat. So if we're not, if our bodies are not doing that properly, we can start to have that overgrowth of some normal bacterial flora again. Same with elastase. Elastase we want to see around 500. So again, this is not why the patient is having an overgrowth of the Bacteroides fragilis, the Clostridia, and the phyla, it's most likely going to be because of that H. pylori infection causing a hypochlorhydria. Beta-glucuronidase. So this is what I wanted to talk about. So she had the elevated Clostridia, which contains beta-glucuronidase. So again, when we see elevated beta-glucuronidase here, we know we have to get rid of the Clostridia. In order to get rid of the Clostridia, we have to deal with the digestive insufficiency. To deal with the digestive insufficiency, we have to deal with the H. pylori. So you start to see how layered these treatments can be and how interconnected all these markers are, which is so fun when you get to put all the information together. So beta-glucuronidase is a major, when we see this high, this is an enzyme that is going to affect our glucuronidation ability or our phase 2 detox in our liver. And there's so many things that go through that pathway, right? Our hormones, estrogen's is a big note when we do see elevated beta-glucuronidase, but mycotoxins, our neurotransmitters, so many things go through that phase too. So I don't want to just say estrogen, but in this patient's case, because we're suspecting that there's some endometriosis, some huge dysmenorrhea, some potential estrogen excess, I think it's even more important to take note of this. So this beta-glucuronidase is high. It's going to inhibit her ability to metabolize her hormones. And so when we see this, we either want to give some calcium D-glucarate, which is going to help to get these estrogens out of her GI tract before they go into hepatic circulation, or some binders. And I do also like to support the liver. So I'll go into all these treatment considerations at our summary. But we're also seeing that there is an elevated secretory IgA. So again, the immune system is overreacting here. I'm not suspecting intestinal permeability in this patient, but I have been wrong before. So because we see this elevated normal bacterial flora, I'm less suspecting that there is intestinal permeability, but like I said, I've been wrong. So I've started testing zonulin on every patient because this is a perfect example of ooh, secretory IgA is high, we don't see any major pathogen. Is this a food sensitivity thing? Is this what's potentially going on? So when we see this, and there's no page 1 pathogen, I am often thinking, is there any food sensitivities potentially present? And then anti-gliadin, we do want to see this under 100 generally, but it's really close to that higher or to the high side of that reference range. So, she would probably be a good candidate to go on a gluten-free diet. So that is our 19-year-old female. So again, just want to highlight some of the findings that we found that could be relating to her clinical presentation. So the dysmenorrhea, again, that high beta-glucuronidase, making it hard for her to metabolize her estrogens and then get them out of her body before going into hepatic recirculation. And then the high Clostridia, because the high Clostridia contains some of those beta-glucuronidase enzymes. So we are going to take note of this and make sure that we're incorporating it into our treatment plan. The digestive disturbance. So again, high H. pylori, very symptomatic for all those upper GI symptoms. The elevated normal bacterial flora, again, telling us that there is digestive insufficiency as part of her picture. High secretory IgA, so maybe some food sensitivities. We do have high Methanobacteriaceae. This can also be a major migrating motor complex issue when we have high Methanobacteriaceae. We've got the high Morganella, really inflammatory microbe, again, histamine producing, can cause a lot of digestive disturbance too. And then the high normal anti-gliadin IgA. So she's got a lot of markers here pointing to why she's got such a bad digestive disturbance. And again, we're going to take that into account. And then the mental health. So same thing as I spoke with the last patient with that high high Clostridia. So high beta-glucuronidase. I'm getting confused. The high beta-glucuronidase, again, can cleave that epinephrine and norepinephrine in the GI tract and make patients more anxious. That's in reference there. The high opportunistic bacteria. Again, these are very inflammatory in nature. The histamines can really affect patients with anxiety. The high Clostridia in reference to the high beta-glucuronidase because they contain that. And then the high H. pylori. So again, H. pylori causes a secondary hypochlorhydria. That's going to affect her ability to be able to digest protein. If she can't digest protein, she's going to have a hard time with, getting amino acids that turn into neurotransmitters. So we do see a lot of mental health with elevated H. pylori infections and that secondary hypochlorhydria. So again, just trying to take it all into account with the overall picture. So this is what I did to treat this patient. First, get the bowels moving and treat H. pylori. So we always want to make sure that our patient is having bowels that are working on a daily basis, because the last thing we want to do is start a kill protocol and nothing's moving, and then she's kind of reabsorbing toxins from that eradication protocol or byproducts per se. So in this patient's case, I am considering antibiotics for 2 weeks because she's got such an overgrowth of normal flora. It would be less detrimental to her. And antibiotics do have a 90% eradication rate when used to completion. So again, I'm really picky on when I use it, but she is so symptomatic. I also really want to get this patient's quality of life into a better state. But I always will kind of give informed consent and have the patient decide. So I'll just kind of tell pros and cons to the antibiotics, pros and cons to the herbals, and then they often are feeling more drawn to one treatment protocol than the other. All right, and so the foundational support, again, the calcium D-glucarate because of that elevated beta-glucuronidase, mag oxide. Sorry, I don't think I mentioned that this patient is constipated. So she is constipated. I'm using mag oxide to get her bowels moving. And then anti-inflammatory herbs to help with the inflammation, removing gluten, elimination diet. So really trying to see if there is any food sensitivities. And then again, considering changing that birth control pill to one that has less effects on mental health. That's right. I forgot to mention that. Or no, I did mention that. So birth control pill is really affecting mental health as well. Phase 2. So we want to, again, get off of any antimicrobials for 1 month. We're going to continue phase 1. So continue rebuilding. And then we're going to retest H. pylori after being off of any sort of antimicrobials for 1 month. Based on those results, that really helps to get us clear on the next step. So if the H. pylori is still present, we want to continue to treat. Again, if we don't get that into a healthier range, all the opportunistic bacteria are going to keep growing back, right? And we're going to have that secondary hypochlorhydria. So I'm really quite diligent about retesting H. pylori when I do see it high, if the patient's finances are able to. If the H. pylori is eradicated, again, then we can do a bit of an HCl challenge, get that, treat the hypochlorhydria and make sure that that is all working so that we're going to prevent any further infection. And then I'm going to start to treat the opportunistic bacteria. So again, the Morganella is a big one. The other ones are important too, but this one's the most inflammatory. So, and it produces biofilm. So want to use a biofilm disruptor. And then I'm going to use rotating broad spectrum antimicrobials because there was a lot of there was 1 gram negative, but a lot of gram positive. So I want to make sure that I'm touching on both. Gram negative tends to be more of the nastier bugs. So that was that Morganella. And then support histamine degradation. So again, this patient's experiencing some anxiety and some of the kind of hormonal issues that can sometimes come with histamine excess. So because we also have that Morganella producing histamine, sometimes I will consider some histamine degrading supplements to support as well. And then retest the whole GI map 1 month after completing the antimicrobials in phase 4. So it really sometimes it is a bit of a windy road depending on what that H. pylori test result comes back as. All right, last case here. So this is a 22-year-old female, has a history of antibiotic use for acne, has PCOS and is insulin resistant, immune intolerant. So just is getting new food allergies all the time, has seasonal allergies, really affected mental health. So has a recent diagnosis of bipolar, suboptimal iron, loose stools, and acne. So let's dive in here with this patient's case. All right. All right, yeah, so this is the deficiency case. So really wanted to just show that a little bit. in terms of what does it look like if all your normal bacterial flora is in a deficient state. So we can see this with case 3. So yes, huge red flag. I really hate seeing case reports or test reports come back like this. Some of my sickest patients, honestly, don't have big infections, but are in a huge deficient state of normal flora. And so I always kind of cringe when I see cases like this, because I just know, there's going to be a little bit of work that we have to do, and we just really, really, really need to rebuild this patient. So this is deficient normal flora, and we'll kind of go one by one as to what these mean when they're in a deficient state. So the low Escherichia in terms of supporting our immune function. So it really induces host immune defense against pathogens, and it strengthens the intestinal barrier. So again, we don't have a ton of pathogens that we can see on this test, but the intestinal barrier is so, so important in terms of supporting and protecting our GALT, our immune system. So the Escherichia will go low if there's reduced mucosal health. And then the use of antibiotics, can also really affect this. In terms of treatment, again, we just want to really support mucosal health. So doing all the things to get that intestinal lining into a healthier state. And I also want to say, because Escherichia produces vitamin K and B12, we want to probably supplement this patient with the vitamin K and B12 because we don't have that Escherichia doing that role. We also have low lactobacillus. So lactobacillus plays a role in immune function in so many different ways, but I won't go into details, just know that. Check lecture 2 if you want to know all the details about low lactobacillus or the immune function of lactobacillus, but it will be caused from a low carb intake and reduced mucosal health. So again, this is 2 for 2 for reduced mucosal health. This is a little bit easier to treat because there are commercial available lactobacillus probiotics, but another way to get lactobacillus in is just by eating fermented foods. So that is often easier for patients. All right, we're seeing low Clostridia. Low Clostridia is going to play an important role with immune function as well. So Clostridia can promote the development of several immune cells that are key players in determining the nature of immunological response to antigens or pathogens ingested. And again, we're just seeing such, new food allergies and such. So Clostridia will result from a low fiber intake and are often associated with inflammatory and autoimmune conditions. So we really want to beef that guy and get that back up. Prebiotics, inulin type fructans can be really helpful. And then polyphenols as well can be really helpful to get Clostridia up. We're seeing low Enterobacter, and this again can be caused from reduced mucosal health. So really supporting mucosal lining. I think that's like 4 out of 5 or 5 out of 5 things that really tell us about that mucosal lining and how it needs some serious help. And then we've got we've seen this picture before, our 2 keystone species below detectable limits, so our Akkermansia and our Faecalibacterium. Akkermansia has a protein that is going to aid in immune regulation and modulation. It's called MUS-T, and it's directly involved in immune regulation enhancement of transepithelial resistance. This is another marker of decreased mucosal health. It can also cause metabolic syndromes and obesity. So again, it's really important for setting our basal metabolism. And there is that new probiotic, again, Akkermansia, that has Akkermansia in it. We're going to support mucosal health. Polyphenols, really, really helpful. This Faecalibacterium, again, really important for barrier function. And when we see that again together with the low Akkermansia, we're really thinking that mucin layer is in a detrimental state and that there's probably some inflammation that's going on because this is our major anti-inflammatory microbe. So apopectin, lots of good research on apopectin for this, and then a high fiber diet. The phyla, when we see them in a deficiency, just tells us kind of how bad this is, right? If our phyla, again, 85 to 90% of our bacteria in our intestinal tract fall into one of these 2 phyla. So if we see this huge deficiency It just tells us, we need to get these microbes a better home. We need to get them a nice mucin layer, and we need to feed them. We need the soluble fiber for these to start to populate again. So we really want to do all the things to get the gut lining healthy, all the things to provide these normal flora with some really beneficial food so that they can start to go into normal range and do all the roles and responsibilities that they have to keep us healthy and to keep our GI tract healthy. And so when we see this, we're seeing huge deficiency, but we're also seeing a lowered secretory IgA. And so secretory IgA, we really need commensal bacteria to induce any sort of intestinal secretory IgA, especially Clostridia and Bacteroides. So they will induce that immune response. And then we have seen deficiencies in secretory IgA be associated with asthma, autoimmune disease, and food allergies. So that does seem pretty applicable with this patient. All right, so insulin resistance, some markers here. Again, the Akkermansia is going to play a big role there. Intestinal permeability can cause inflammation, and inflammation can cause the insulin to start to go up. Immune intolerance, that low Clostridia, the low Faecalibacterium, low Akkermansia, really important for immune function in our GI tract and overall health. And then the mental health. So, this is really important. And I didn't go into this in either of my previous lectures, but our normal flora actually can produce neurotransmitters as well. So I just wanted to make a note here. She had low Escherichia. Escherichia is important for producing norepinephrine and serotonin. And then low lactobacillus. So lactobacillus can produce acetylcholine. Acetylcholine is also it is one of the major triggers for our body to know to produce HCl. So when we see low lactobacillus, we can also kind of indirectly infer that there might be some hypochlorhydria, because that acetylcholine from the parasympathetic neurons trigger parietal cells to produce HCl. So I thought that was a really cool connection too. I'm going to probably want to do an HCl challenge on this patient and just make sure that she isn't hypochlorhydric, and that's playing again a bigger role into this mental health with her inability to break down protein or inability to get amino acids turned into neurotransmitters. And then so GABA as well. So really cool. Oh goodness, there's one really great researcher with gut health and mental emotional, and you're gonna have to do some Googling because I forget the name right now, but lots of cool stuff coming out in terms of gut health and mental health. So that's just a couple things I thought I'd tie together. So this case, really, we are just thinking rebuild, 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 reinoculate, 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 just get everything into a healthier state. So we're going to do some GI rebuilding supplements, some soluble fiber with inulin and apopectin, really important for that Faecalibacterium. Butyrate, again, we've got the low Clostridia, the low Firmicutes, the low Faecalibacterium. All our butyrate producers are in a deficient state. So we know we need to supplement butyrate, the Akkermansia probiotic, the lactobacillus probiotic, and polyphenols. And I often will do that for 4 to 6 months. So not only do we have to rebuild the normal flora, but we really need to get the foundation strong. The high fiber whole foods diet, add the fermented foods. Cod liver oil. Cod liver oil is great in terms of the omega-3s is going to help with healing the intestinal lining, but vitamin A has the ability to enhance antibiotic responses, especially IgA antibody responses in mucosal tissue. So the vitamin A is really helpful with our mucosal immunity. So cod liver oil contains high levels of vitamin A, and that's often why I am suggesting that, unless your patient is wanting to get pregnant, then we want to avoid any sort of vitamin A. Assess for the hypochlorhydria, again, that connection between lactobacillus being able to produce acetylcholine, and that's a major activator of HCl production. And then some B vitamins and K2, because we have that deficiency in the bacteria that's going to produce the B vitamins and the K2. So this is our deficient patient. This is the treatment plan that I did with her. I really thank you all for being here. I just want to end with a bit of a summary slide. You guys are all experts now. You know all of this information, just how important our normal bacterial flora are. So oftentimes, practitioners are leaving this to the last step in their treatment plan. And I find that, it probably has a place, especially when there's a state of deficiency, to be a bit more of a priority. And so again, I'm going to run through this quickly because I know time is so precious for everyone, but it's going to enhance the epithelial barrier. Again, that's so important in terms of protecting our immune system from the contents of our lumen. They're going to develop and modulate the immune system. So much great research on how germ-free environments really stifle our immune development. They produce anti-microorganism substances, so prevents and kills off any sort of pathogens. They also competitively exclude and inhibit the epithelial adhesion of pathogens. So they kind of crowd out pathogens and they prevent their adhesion to the cell walls to prevent infections. They produce energy substances that most often that's that butyrate, really important for colonocyte health. Produce vitamins, the K2 and our B vitamins, and then support our metabolism. So please, please, please always keep a watchful eye for the state of these normal flora and treat accordingly. Thank you so much for taking the time to listen. Really appreciate you being here, and I hope you can take home some of this tangible information and work it into your treatment plans. Have an absolutely wonderful rest of your day. Take care.